Alrighty, so it looks like a couple of folks are starting to join in, so I'll go ahead and get started. So hello everyone and welcome. Thank you so much for joining us today for the National Hispanic Medical Association's Next Steps, an overview of the current epidemiology and treatment of HIV in partnership with the American Academy of HIV Medicine. My name is Jason Hernandez, Program Manager here at NHMA, and I'll be serving as today's moderator. The National Hispanic Medical Association is a nonprofit association representing the interests of nearly 50,000 licensed Hispanic physicians across the United States. NHMA's mission is to empower Hispanic physicians to lead efforts to improve the health of Hispanic and other underserved populations in collaboration with Hispanic state medical societies, residents, medical students, and other public and private sector partners. Joined with me today is Scott Brawley, the Development Director of Policy and Programs at the American Academy of HIV Medicine. I'll turn it over to Scott to say a few words.
Good afternoon, good morning, everyone. Welcome to the webinar, and thank you for joining us in collaboration with the National Hispanic Medical Association. Just wanted to introduce the American Academy of HIV Medicine briefly. We are the nation's largest independent organization of physician assistants, pharmacists, nurse practitioners, and nurses and other HIV care providers that treat the majority of people living with or at risk for HIV in the United States. We have four main pillars of activity. One is educational offerings, such as this accredited webinar of today. We also have some clinical education online available for you, and I will drop some links in the chat later for you to access if you have interest in additional information on our educational offerings. We do certify physicians and pharmacists and others as specialists in the field if you pass the credentialing examination. We connect providers across the country through state and local chapters, as well as by profession. So if you're a nurse practitioner and want to connect with other nurse practitioners in the field, we can help you with that as well. And lastly, we advocate on behalf of the HIV care team with Congress, the administration, on behalf of people living with and at risk for HIV. And again, we thank you all for joining us this afternoon. Happy to partner with Dr. Martinez and NHMA to give you this offering today. Thank you.
Thank you so much, Scott. So today's webinar has been designed to meet the educational needs of physicians. However, healthcare providers of all backgrounds are encouraged to attend. With that being said, I'll go ahead and read the accreditation statement. So in support of improving patient care, this activity has been implemented by MEDCO and the National Hispanic Medical Association. And MEDCO is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. Next slide. And MEDCO designates this live activity for a maximum of 1 Category 1 credits. Physicians should only claim the credit commensurate with the extent of their participation in this activity. Next slide. For the disclosure of unlabeled use, this educational activity may contain discussion of published or investigational uses of agents that are not indicated by the FDA. The planners of this activity do not recommend the use of any agent outside of labeled indications. The opinions expressed in the educational activity are those of the faculty and do not necessarily represent the views of the planners. Please refer to the official prescribing information for each product for discussion of approved indications, contraindications, and warnings. In this activity, the faculty do discuss the use of investigational antiretroviral agents and treatment regimens that are not approved by treatment guidelines. Next slide. Participants have an implied responsibility to use newly acquired information to enhance patient outcomes and their own professional development. The information presented in this activity is not meant to serve as a guideline for patient management. Any procedures, medications, or other courses of diagnosis and treatment discussed or suggested in this activity should not be used by clinicians without evaluation of their patient's conditions and possible contraindications on dangers in use, review of any applicable manufacturer product information, and comparison with recommendations of other authorities. Next slide. And lastly, this is a no fee for this educational activity. With that being said, it's my honor to introduce to you all our guest speaker, Dr. Dora Martinez, Chief Medical Officer of the Valley AIDS Council. Dr. Martinez is a member of the American Academy of HIV Medicine, as well as NHMA and a former NHMA Leadership Fellow. Dr. Martinez, thank you so much for taking the time to be with us today. I'll turn it over to you.
And as a speaker, I have these disclosures. I've been on the Speakers Bureau for Gilead, Janssen, and ViiV, and I have received research funding from ViiV and Gilead. So today's learning objectives are to look at current epidemiology and spread of HIV in the US and factors affecting the spread of HIV, to discuss when to initiate treatment for persons with HIV, to help differentiate between people with HIV with a detectable and undetectable viral load and how this contributes to new infections, compare and contrast the recommended treatment regimens for people with HIV, especially for those that are newly diagnosed, and assess future treatments options for HIV and evaluate HIV cure research. Next slide, please. Thank you. Agenda. So again, we're going to look at epidemiology. We're going to look at the treatment and focusing on when to treat and what to treat with, looking at future treatment directions and cure research. So for introduction, so who, joining the webinar, where do you feel you fall, into these categories? That you don't have patients with HIV and don't prescribe HIV treatments. You don't have patients with HIV and have not prescribed, but would like to. Have a few patients with HIV and have prescribed antiretrovirals a few times. Have numerous patients with HIV and regularly prescribe antiretroviral treatments. Or you're not in a position to treat patients with HIV, but have an interest in HIV currently. Let's see here. And so the good thing about this webinar is it's really going to, focus on all the options, no matter where you're at, right? So we're going to be talking about a case as we kind of walk through this. And so the case for today is that you're reviewing your daily schedule and your medical assistant advises you that you'll be seeing a newly diagnosed patient with HIV. It's a last minute add-on, and so you don't really have many details on the patient yet. So take a moment to think who this patient might be. Might they be younger or older? Are they female, male, or maybe non-binary? What is their race? What is their ethnicity? And so this is going to help us get into the epidemiology. Next slide, please. So HIV prevalence. This is data from the CDC from the 2019. And one of the things that we know is that the burden of new HIV diagnosis is really felt in the South and in persons of color. And so we'll see here that the HIV prevalence for 2019, the darker states tend to be along the South and on the coasts as well. And the darker the state, the more HIV prevalence there is. In 2019, there were 36,801 people newly diagnosed with HIV, and this has been pretty steady. We look back at the last 10 years. Typically, we'll see about 34 to 36,000 new diagnoses in a year. Majority of these diagnoses come from gay and bisexual men, and 69%, about 23%, almost a quarter in heterosexual men and women, and about 7% in people who inject drugs. There have been overall decreases in new diagnoses between 2015 to 2019, a decrease in 9%. Unfortunately, decreases don't always happen across the board evenly, but the good thing is that there has been an overall decrease. Next slide, please. So the incidence is decreasing over time, as we mentioned, and we can see that here between 2010 and 2019, that overall, HIV in persons age 13 and over, the diagnoses have been dropping, which is good because there are strong initiatives to end the HIV epidemic. So we want to see this happening. This is good that there are overall decreased diagnoses. Next. But it's not the same across all age groups. It's not the same across all ethnic groups, etc. Here we'll see that the overall between 20 and 19, there was that decrease in new HIV diagnoses. We see that there is this increase, particularly in the age group of 25 to 34 years old. And I can say that in my clinical practice, that does tend to be where we get the most new cases from, and the new diagnoses. One of the things that's not really highlighted here, but it's important also just to keep in the back of your mind, is that if you look at the line for over 55 years, it's not a big upward trend, but there has been an upward trend also in diagnoses over the age of 55, but the majority are 25 to 34-year-olds. Next slide. So what do you think might be the lifetime risk for HIV for all people in the United States? 1 in 56, 1 in 120, 1 in 245, 1 in 500. Where do you think we stand for overall lifetime risk of HIV in the United States? Next slide. It's 1 in 120, right? So this is based on data between 2017 and 2019 in an abstract that was presented at CROI last year, 2022. But the overall lifetime risk of HIV was that 1 in 120 Americans will have HIV in their lifetime. If you're a male, it's 1 in 76. If you're a female, it's 1 in 309. But we will see in the upcoming slides that this really also depends where you live and what your background is, or who you are, what your risk will be, and what communities you live in, because 1 in 120 may not seem too bad as an overall rate, but we're going to see that that burden of HIV really is in the South and in peoples of color, and also in men who have sex with men, and that it becomes pretty staggering when we see that data that's coming. Next, please. So the lifetime risk of HIV diagnosis by state. Again, the darker the color of your state, the higher the likelihood of the lifetime risk of HIV is. I am in Texas. I'm in the Rio Grande Valley of Texas. And for the state of Texas, 1 in 93 Texans will be diagnosed with HIV in their lifetime. The highest risk is in the District of Columbia. And if you see over here, DC, 1 in 39 residents of DC will have HIV in their lifetime. That's a pretty staggering number, right? And so we also have to remember that it's also not just about the individual, but about the community. What is the community incidence? What is our, quote, community viral load? Because that can increase our risk, despite what we consider our own personal risk of HIV. And again, really the South is carrying the burden of new HIV diagnosis. Next, please. So disparities. We know that disparities exist. It doesn't just exist in HIV. It has existed in COVID. It has existed for maternal outcomes, right? For a lot of different diagnoses, there are health disparities. Next, please. And so we have HIV being no different. There are definitely, disparities. So what might you think are the 3 groups at highest risk of HIV in the United States? Black males, Latino males, Hawaiian Pacific Islander, Black and Latino males, white males, Black and Latino males, Black women, Black and Latino males, or Asian males. Next slide, please. The 3 groups at highest risk based on their ethnicity are Black men, Latino men, and Black women. And the risk per group is 1 in 20 for Black males, 1 in 50 for Latino males, and 1 in 75 for Black women. And again, this is data that came out of CROI in 2022. And so this is something that we need to tackle as a health disparity, right? And educating within our medical communities that serve these groups and serve these communities, because it needs to be on our mind, right? That this is a possibility, regardless of what we may consider our risk groups. And so these lifetime risks are significantly different, right, than the, quote, general population. And so we do need to think about it. And one of the things that we're going to see that for me is very staggering is that if I am a Black man who's gay or bisexual, a Black man who has sex with men, that risk goes from 1 in 20 to 1 in 2. If I am a Latino man who has sex with men, my risk is going to go to 1 in 4. And that is really, really staggering. That if I am a Black man, 1 out of every 2 persons like me, if a Black man who has sex with men, will have HIV in their lifetime. That is a very, very important health risk that needs to be properly educated, properly addressed. Next. And for Black and African American people, just in general, make up 14% of the US population, but 46% of new diagnoses of HIV for 2019. And for Latinos, 18% of the population, but 29% of new HIV diagnoses. Again, we see this health disparity. And this is why it's so important to get education out to our communities, out to the places that are serving these communities of color. Next. And this is what I was mentioning. 1 in 2 Black men who have sex with men are at risk of HIV. That is staggering. 50%, half. If I am someone within that community, right, then I probably already know someone with HIV, And I probably know that I am at risk of HIV. And if I don't know, I need to get information. So how is that information going to get to me? And also about prevention of HIV, because we do have preventive options now. And unfortunately, a lot of times those prevention options, the education about it, the access isn't making it to the folks that are really in need of it. Next slide. Any questions or needing clarification for the section that we've just gone over about the epidemiology?
Dora, we did have a question from Salvador in the chat. Can you comment on the difference between males and females in the US versus Africa? Maybe also speak to HIV-1 and HIV-2. I did drop an answer in the chat box, but I'd love to hear your answer as well.
Yeah, so we're talking about completely different populations, and I'll be honest, I don't know the epidemiology of HIV in Africa like the back of my hand, like I do for the US, but there's different drivers, right? There are different drivers of HIV in different communities. Largely, regardless of the type of sex, it is driven by sex, whether it's vaginal sex or anal sex, but sex is the largest driver of HIV transmission, though it can be obviously transmitted through blood to blood, intravenous, etc., and of course perinatal transmission, which is another big difference in Africa versus, say you were specifically talking about the United States, is that perinatal transmission is also largely affected by treatment. And if folks are not diagnosed, treatment particularly, childbearing, then there will be more incidents of HIV transmission. And also a difference between Africa and the United States for transmission is that in the US, for most folks, you have, accessible clean water and formula as an option for feeding. That is not necessarily the same in Africa and settings like that, where you need to use, own breast milk. So there's a different, transmission possibility there as well. So continuing with the case. So the patient is Antonio. He's 25 years old. He's a cisgendered Latino male who has sex with men. He tested positive for HIV 2 weeks ago. He's been getting fairly regular STI and HIV screenings every 3 to 6 months, and he last tested negative for HIV 6 months ago. He wants to know what the next steps are and if he can get started with treatment right away. So what do you do next? Would you order baseline labs and recommend treatment start when you have results? Would you order labs and recommend a treatment start when the CD4 count is under 500? Would you order labs and start treatment today? Or order labs and refer to an HIV specialist for treatment? So we're going to go over when to start HIV treatment and what the data is. So in 2015, there was the START trial, and the START trial truly revolutionized the HIV guidelines because in 2016, the guidelines changed. And prior to this change, HIV treatment was really based on how sick you were. Were you symptomatic? Did you have advanced HIV or quote AIDS? What was your CD4 count, right? Were you having symptoms? And so you could be offered treatment if your CD4 was over 500, but it was just offered, are you interested? It really wasn't a strong recommendation or guideline to start everybody on treatment, but maybe you could offer. So basically what this trial looked at was following the guidelines versus let's offer it and start everybody on it, regardless of how sick they may or may not be, regardless of what their CD4 is. And what this found is that all-cause morbidity and mortality was lowered by starting folks with HIV on treatment, right? And in 2016, the following year, the guidelines changed to offer treatment to everybody. It wasn't like a strong, everybody must be, but hey, this is really good evidence. Everyone should be at least offered to get started on treatment, because it looked not just at serious, quote, AIDS-related events, but non-AIDS related events. All-cause morbidity and mortality was affected by starting HIV treatment. It was improved by starting HIV treatment, regardless how sick or not sick the individual was. So this made a big change in the guidelines. Next slide, please. So immediate treatment start prevents morbidity and mortality across the board. That is the main idea of this. And this is why getting folks who are diagnosed with HIV on treatment is so important. Next slide. It also helps to prevent transmission in serodifferent or serodiscordant couples, right? And there's been a number of studies that have demonstrated this. Here we have HPTN 052, which looked at HIV serodifferent couples that were randomized either to early or immediate treatment versus treatment when the CD4 fell below the standard of care. So start everybody soon or follow the standards, follow the guidelines at the time. There was over 1,600 heterosexual couples that were followed over 10 years. 8 of the HIV transmissions within couples were after the HIV infected partner was given ART. 4 of these 8 cases were diagnosed soon after ART initiation and transmission. 4 of the HIV infected partners had detectable levels of virus in the blood despite being on treatment. So these were treatment failures where the regimen wasn't working. There was no HIV transmission observed when the partner was fully virally suppressed, right? So this is where we really started the data and the science of U equals U, or undetectable is untransmittable. Next slide, please. More studies, partners and partners too. So in partners, there were all serodifferent couples. There were 1,166 couples, either heterosexual or gay, and a total of recorded 58,000 sex acts without condoms. In partner 2, it was 800 gay couples with 77,000 sex acts without condoms. And in opposites attract, there were 358 gay male couples with over 16,000 acts of anal sex without condom, and all showed no linked transmissions. So when the positive partner is on treatment and controlled, there is no HIV transmission through sex. So again, the science has been made clear, and this really came out in 2019 as the messaging of U equals U. Excuse me. So really, there is no risk of HIV transmission with an undetectable viral load. Now, this is the caveat. This has not been studied for IV drug use. And there are emerging data for perinatal transmission, but the kind of blanket statement of U equals U has not been made yet. But in CROI last year, there was a data review that showed highly unlikely, essentially U equals U for perinatal transmission when there is an undetectable viral load. But the important thing to know is not getting to undetectable once. It's about getting to undetectable and maintaining an undetectable viral load for at least 6 months. Next slide. So what is undetectable? When we say undetectable, what is that viral load cutoff? Is it 20? Is it 40? Is it 100 copies, 200 copies, or 500 copies? What do you think? It's less than 200. The way I explain it to my patients is that the 200 copies is kind of the government standard, if you will, right? So this is what we look at for viral suppression, is under 200 copies. Now, if you're running an HIV clinical trial for the FDA, that standard is usually going to be 50 copies. If I'm looking at the lab that we use, it's 20 copies. But at the end of the day, control is control. If you have a viral load under 200 copies and it maintains under 200 copies, we will not have HIV transmissions through sex. Next, please. So looking at HIV transmission in the HIV care continuum. Excuse me. So the HIV care continuum, really it's getting diagnosed. When you're diagnosed, getting into treatment, getting retained in care, getting a prescription for treatment, getting on treatment, taking your medication, getting to viral suppression, hopefully staying there. What we see is that the majority of HIV transmission happened in 2 groups. The folks with HIV that have not been diagnosed, so they have HIV but don't know their status, or the folks who were diagnosed but never got into care or didn't stay in care, right? So they got their diagnosis, but then never got to a clinic, an organization, a support, etc., where they would actually get engaged in care. And go ahead and click the slide, please. we see that 92% of new HIV diagnoses are essentially generated by those two groups, right? I didn't know I had HIV, or I kind of found out, but I never got linked into care and never really started treatment. So this is why linkage to care is so important, and testing is so important, right? I can only know my diagnosis if I get a test. And if I'm in a group, remember about a quarter of folks, the 23% were in the heterosexual, were kind of automatically deemed not at risk, right? When we think about it, that a quarter of folks with HIV would not get a test just because they're deemed not at risk. That's a lot of folks. But even beyond that, most folks aren't getting a test, whether because of time or fear or stigma, right? And in primary care settings, especially, it is so important to follow the guidelines, the CDC guidelines, USPSTF, et cetera, basically every major medical association has a recommendation. So making sure that we're properly screening folks so that we can identify new positives and get them linked into care. Next, please. Because treatment is prevention. And this is part of what we see with the U equals U, right? Undetectable is untransmittable, which transmits into or translates into treatment is prevention. So if we can identify folks with HIV and get them into care and get them treated, we can prevent new HIV transmissions, because we will not have new transmissions through sex because of U equals U. Next, please. And then rapid start. So this is another kind of new tool in our arsenal to help end the HIV epidemic. This is data from San Francisco that was collected between 2013 and 2014. They piloted a rapid initiation treatment plan called RAPID. And the goal was to link folks into care within 5 days of their HIV diagnosis and start treatment within a day of their first visit. So persons with the rapid ART start or rapid start were more likely to be virologically suppressed, not just starting off, but a year out, right? So call it durable viral suppression, right? So coming in, getting the treatment, staying in care, staying with an undetectable viral load 12 months out from diagnosis. And this was true only for those in the rapid start and not the non-rapid start. So folks that started treatment kind of traditionally, oh, you might get a referral, you might wait for labs, you might, et cetera, et cetera. There's these delays, did not see the benefit, even though they were also linked into care. So it highlights why starting someone on treatment as soon as possible from diagnosis can be important. Next slide, please. Right, and so this is what I was saying, starting treatment at early increases likelihood of remaining virologically suppressed. Remember, U equals U isn't a one-time thing. For U equals U to exist, there has to be sustained undetectable viral load. So if you're more likely to be engaged in care and continuing to take your medicine and coming to your visits, well, you're more likely, right, to have that suppressed viral load and to help not transmit HIV and be linked to new diagnoses. Next. So when to start treatment. So the updated DHHS guidelines recommend starting treatment as soon as possible, including the same day of diagnosis. And what they have found is that this, rapid start or immediate initiation of ART, why it matters is that it increases the uptake of ART and linkage to care. It decreases time for viral suppression and improves the overall rate of viral suppression. I tell my patients, what's good for the individual is good for the community. I don't just control my own viral load, I control my community viral load. And so being selfish, so to speak, taking care of me, takes care of my loved ones, takes care of my community, takes care of my partners. And the sooner that each individual gets to undetectable, the sooner that community viral load gets under control. Next. Any questions on that section?
Dr. Martinez, we do have a question in the Q&A box. What is the standard when talking about U equals U with regard to breast milk?
So there is emerging data for breastfeeding. There isn't a U equals U message yet or consensus yet for breast milk. The guidelines have changed that, it can be done low risk. There's no such thing as no risk, right? but it is lower risk, small percentage of transmissions in the data that's been shown, but there is no U equals U message as of yet for breast milk, just because there isn't at least yet seen a complete elimination of the risk, though it is a very small risk. It's not even a 1% risk.
If you're interested in more information on this topic, the Academy does have an online course on women and HIV with one specific module on pregnancy and breastfeeding.
Yeah, it'd be great if we could say that it was a U equals U standard across the board for all routes of transmission, but we're just not there yet. But the risk is very low. So moving on what to start and what is in the guidelines. So this is the HIV life cycle or replication process. I like to go through this with my new patients. I sit there and draw on paper and we go through the life cycle. But basically, what has to happen is HIV has to get in, right? And HIV gets in through the receptor. Typically, it's the CCR5 or CXCR4 receptor. But so it comes in, basically lets itself in, and comes in with RNA. So you have the fusion of the HIV to the cell, it comes in, and the RNA comes in along with some enzymes, some helpers, right? And the first is reverse transcriptase. And in layman's terms, essentially what it's going to do is read the information provided by the RNA and make a copy so that we can have HIV DNA, right? As we know, we are DNA creatures. We require the DNA information to help run our computer program. So the viral DNA now gets formed and can communicate with our own host DNA, but it's going to do that with the help of another enzyme called integrase. And so integrase is actually going to integrate that new HIV DNA into our own cell, into our own DNA, and kind of like a computer virus, right? Take over the process, change the program of that CD4 cell, and basically turn it into an HIV factory where it's going to start using our own parts to make new HIV RNA, new viral RNA. There's another step, maturation, step 5. I usually like to call it packaging up. It's going to use this enzyme called protease, and essentially what it's going to do is make sure that all the RNAs are cut up just properly, they're packaged up just right, and then sent out, right? So you have these new viral RNA proteins that can move off the surface, off the cell, and a mature virus now can go and find a new cell to infect. But basically, the way I explain it to my patients is you have to get in, you have to read the information, copy of it, make a copy, take over the cell, turn it into an HIV factory, package it up, and ship it. And this is where our HIV medications work. Next step, please. Next slide. So HIV treatment has come a heck of a long way, right? In the 1980s up to about 2007, we really didn't have a lot of places that we could target the HIV life cycle. And at first, all we had were our NRTIs, or nucleoside reverse transcriptase inhibitors. This is, AZT, for example, which was first approved in 1987. And you could partner them up 1 at a time, 2 at a time, 3 at a time, and they would work for a while, but then the HIV would kind of outsmart it and figure things out. And then the viral loads would go back up. In December of 1995, one of the best things to happen in HIV treatment was that the first protease inhibitor, saquinavir, was introduced, right? And so in 1996, for the first time ever, we could really use truly combined highly active antiretroviral therapy, where we could go after the HIV at 2 life cycle sites, more than one place. And this we really started to see make a difference in terms of surviving HIV and having a life with HIV. In 2006, another kind of big shift was that the first ever single tablet regimen hit the market and could be used. Was it the best treatment ever? Was it the most tolerable treatment ever? No. But did I have to take handfuls of pills multiple times a day, the supposed, the HIV cocktail? I could take 1 pill once a day and be done with my treatment. And it revolutionized things in terms of, quote, the ease of treatment. Next step, please. Next slide. Continuing on in 2022, we have more options now. We have more options that are more effective, they work better, they work faster, and they're more tolerable than some of the treatment options we had, heck, even 10 years ago, but certainly 20 and 30 years ago. Now, we have the protease inhibitors and the reverse transcriptase inhibitors, but maturation inhibitors, entry inhibitors, and integrase inhibitors, which really integrase inhibitors have changed the face of HIV medicine and how we treat HIV and how people experience HIV treatment. They really have become the mainstay in the guidelines for treatment. Next slide, please. And here you will see we have options. And options are a wonderful thing when you're treating an illness, a virus that can mutate and can change, right? There are more than 30 antiretroviral drugs available, including over 10 single tablet regimens. So not only do we have options for overcoming resistance when it's necessary, and most of the time we can overcome resistance when needed, but more than ever, there's options for ease, simplicity of a single tablet regimen, which isn't just about convenience, right? It's about being able to protect the regimen, take it all together, not have a missed dose. But yeah, it also makes it easier for me to be adherent if I only need to take one pill once a day. And if I'm taking my medicine, remember, that helps me maintain viral suppression and helps me to end the HIV epidemic within myself and within my community. Next slide. So what are the DHHS recommended initial regimens? So first we have BF-TAF, bictegravir, emtricitabine, tenofovir, alafenamide. Then we have dolutegravir, abacavir, lamivudine, with the asterisk being that if anybody's going to use abacavir in any regimen, you must have an HLA-B5701 test, because if it's positive, you will have an adverse hypersensitivity reaction. And it's also really important to know that though this regimen contains lamivudine, lamivudine alone is insufficient to fully control hepatitis B infection, where, for example, the emtricitabine tenofovir regimens will have kind of built-in hepatitis B treatment. There's also the option for a 2-tablet regimen of dolutegravir plus either emtricitabine TAF, tenofovir alafenamide, or with TDF, tenofovir disoproxil, or instead of emtricitabine, lamivudine could be utilized as well. And then we also have a single tablet regimen of dolutegravir lamivudine, which within the guidelines is recommended for use as the clinical trials were set up, focusing on the viral loads of 500,000 and less. Again, no Hep B co-infection because lamivudine alone is insufficient to treat unless you're adding something else. And you'd want to have a genotype available in the event that there may be resistance to either of the components. Next. And so the most important thing to know about the 4 initial regimens that are recommended is that they're all integrase-based regimens. And so, as I mentioned, integrase inhibitors really did revolutionize HIV treatment and are now the mainstay of care for most people. Next. They're well tolerated. Few drug interactions. They play nice with other medications as opposed to some of the boosted regimens that we had before, some of the other medications that had different drug interactions, and they have a high barrier to resistance. So they kind of have built-in resistance to resistance. They're harder to figure out for the HIV in terms of mutations. Next. So, which is what we're going to see here, talking about the genetic barrier to resistance. So what about transmitted resistance? So McClung presented with the clinical infectious diseases in 2021. There were over 50,000 persons in this analysis looking at resistance, HIV mutations. 9,616 or 18.9% of these persons in the analysis had at least one transmitted drug resistance mutation. 0.8% were noted to be for integrase inhibitors, 4.2% for protease inhibitors, 6.9% for the NRTIs, and 12% for the non-NRTIs. So resistance is never impossible, but it's not likely with the integrase inhibitors. And this is true of any regimen, no matter how good it is. You know, if we kind of mistreat it enough, right? If we off and on, and we allow this to happen, no regimen is infallible, right? All regimens can fail, but it's really difficult for the integrase inhibitor regimens to fail. Next. So in rapid start, what changes in a rapid start setting with the recommended regimens? Well, with the recommended regimens in rapid start, we're going to end up keeping 2. Go ahead and tap the slide. And go ahead and just, there we go. So what we're going to have left, keep going, is going to be that BF-TAF, bictegravir, tenofovir, alafenamide, emtricitabine. And go ahead and click again. There we go. And the dolutegravir plus either emtricitabine, lamivudine, or TAF or TDF, right? So these are really the guideline regimens for rapid start. And why these? So within these regimens, you have the built-in Hep B co-infection coverage, just in case. And if you have the well, it's not super common. The CDC reports that an M184V mutation is occurring at about 0.6% in the United States, so not even a full 1%. But if there is a transmitted mutation of resistance, it might be an M184V, which will knock out emtricitabine and lamivudine, right? So in the event that someone has this transmitted mutation, the tenofovir present in these regimens overcomes that mutation and maintains coverage. So these are the 2 rapid start integrase-based regimens recommendations, the BF-TAF and the dolutegravir, usually F-TAF or FTDF regimens for rapid start. Case 2. So we have Monique. She's a 46-year-old trans woman who was diagnosed with HIV in the 90s. She's been on various treatment regimens and can't recall them all. She's been off treatment for the past 5 years, a period when she was dealing with opiate dependence. She's now in remission and is motivated to improve her health and would love to start treatment as soon as possible. On review systems, she complains of headaches, and you note that her vitals show a fever of 101. Next. So this is a patient with established HIV, off treatment, and coming in with a headache and fever. Would you feel comfortable starting treatment today? Yes or no? And there we go. So when should we consider pausing, right? Pumping the brakes a little bit on a rapid start, right? So this is a highly treatment experienced patient. Sometimes we have to, think about, keep in mind what regimens may they have already been on, may they have underlying resistance, right? So that's something to take in consideration. Someone who may be coming in a little sicker, or maybe they have other comorbidities. They may have some renal issues, right? And so wanting to know what to start if they have, renal issues, a GFR under 30. And also, there are some opportunistic infections where really you would want to delay treatment because of the high risk of IRIS, or immune reconstitution inflammatory syndrome, where someone can actually get worse before they start to get better. And these 2 particular opportunistic infections are cryptococcal meningitis and TB meningitis. And so, for example, this person is coming in with fever and a headache and off treatment for a while. These are not impossibilities, right? So they're things to keep in mind when you're having this situation of a, quote, rapid restart, something coming back into care. Next. So the DHHS recommended initial regimens. We talked about the BF-TAF, the dolutegravir, bacavir, lamivudine, the dolutegravir plus either the emtricitabine, lamivudine plus TAF or TDF, and the dolutegravir, lamivudine. All of the regimens that don't include TDF, tenofovir disoproxil fumarate, can be used with a GFR of 30 and over, with the exception that TDF needing a GFR of at least 60. So that's, they're pretty well tolerated within a renal realm. And so thinking about that, but it's important to keep in mind that TDF. And then with the dolutegravir lamivudine as a single tablet combination, you do want to monitor if they have the GFR between 30 and 50. Traditionally, for a renal compromise or chronic kidney disease setting, lamivudine can be renally dosed in a fixed tablet regimen. It's not renally dosed, right? It's the standard regimen that it comes in a single tablet. So you would want to just monitor that a little bit closely. But with the exception of the TDF, all can be used with that GFR of 30. Next. So opportunistic infections and treatment. So I mentioned, the immune reconstitution inflammatory syndrome, where you can get this paradoxical worsening of pre-existing infection and inflammation and cancer following ARV start, right? And so the two scenarios where you really want to kind of allow for at least 2 weeks of treatment before starting antiretrovirals is going to be the cryptococcal meningitis and the TB meningitis. So who you gonna call if you need help in a rapid start scenario, or really any treatment scenario? So there's always the HIV worm line, 1-800-933-3413 in the National Clinical Consultation or Clinician Consultation Center. And your AETCs have put out immediate ART quick guides. There's these pocket guides, you can print them out, you can fold them up. They're like these little brochures you can put in your pocket. But it's really helpful, and you should always reach out to your local AETCs for guidance, for help, for presentations, etc., because they're always there to help with your treatment and prevention for HIV. Next questions. I think I saw one pop up here. So. Can Dovato or Juluca? So can dolutegravir, lamivudine, or dolutegravir rilpivirine be used as initial regimens? Dolutegravir, lamivudine is actually in the initial regimens recommendations or the DHHS guidelines with that little asterisk of the viral load, etc. Dolutegravir, rilpivirine, or Juluca is approved only for stable switch. So it's for switching someone that has already been virologically suppressed for at least 6 months. So back to the first case. Antonio comes back to discuss his labs and treatment, and he's been taking it. His labs show that he has no transmitted treatment mutations. He's immune to hepatitis B. He was vaccinated as a child. He's no other medical conditions aside from the newly diagnosed HIV. He's tolerating his regimen well, but he admits that he finds it exceedingly hard to take his medicine regularly due to his work schedule, which varies from day to day. Next. So what options does Antonio have that may help with his adherence, right? Could he use blister packs, use his phone alarms, his medication next to his toothbrush, or could he transition to an injectable antiretroviral regimen? Really all of the above, right? Because whatever works, works. And this is one of the things I do talk to my patients is you figure out how to, the great thing about a single tablet regimen, especially like what he's taking here, that's 1 pill once a day with or without food, is that you can make it fit your schedule as best as possible. So if you're not used to taking something every day, figuring out how to make it work for you, is possible. But also transitioning to an injectable is a possibility as well if they've been virologically suppressed for at least 6 months. Next. So future directions, 2-drug regimens. There are currently 3 2-drug regimens that are available. 2 are indicated for stable switch, and 1 also has the indication for initial treatment, and that's what we were talking about. So 3-TC dolutegravir, that 2-drug regimen can be used for initial treatment as well as switch. And then the dolutegravir rilpivirine and cabotegravir rilpivirine are both approved for stable switches off of other treatments. Typically, you cannot use these regimens for folks that are Hep B co-infected, active co-infection with hepatitis B, because you would lose the control of the hepatitis B that was built into the other regimen. Now, if you need to switch for some other reason of tolerability, then you'll have to come up with a different treatment regimen specific for the hepatitis B, of course. Next. So talking about long-acting regimens. So long-acting cabotegravir rilpivirine was FDA approved in 2021. It is an intramuscular injection that can be offered every 1 or every 2 months, every 4 to 8 weeks, depending on which dose is being used. It does require an in-office visit. Right now, the way that it is approved is an injection administered by a healthcare provider. And the most common adverse effect is an injection site reaction. So when I tell my patients about this, I tell them it's a shot. In fact, it's 2 shots, 1 in each buttock or quote hip. It's the anterior buttock, right? You're going to feel it. You don't necessarily feel a pill being swallowed, but you are going to feel a deep muscle, depot injection. And that might be a bruise or a soreness or et cetera, et cetera. So that is the number one adverse effect that is reported, is that it was a shot and I felt it. Next. There are also other long-acting regimens. Recently approved was lenacapavir, which is a capsid inhibitor. It's twice yearly. It's a twice yearly injection. This right now is approved as an add-on. So folks that maybe are not having optimal suppression or other reasons, you know, they need to, maybe their treatment experience, but needing to have that extra help for viral control. There was also islatravir, which was long-acting, it was very versatile in terms of it could be used oral or injection or actually as an implant. However, development was halted in the phase 1 trials. Seemed really promising. I know I had my bubble burst when I was like, oh darn, because it seemed to have some effects on CD4 cells, but as of right now, its development is halted. Next. So what about cure? So research is looking at sustained ART-free remission and then viral eradication. And I know when my patients, you know, mention, oh, they're never going to look for a cure. There's no money in the cure. There is money in cures. Look at hepatitis C, right? I always remind them to look at hepatitis C cures and to remember that those types of treatments are actually very similar to HIV treatment. It's just HIV is a different virus than the hepatitis C is. Next slide, please. So cure research is definitely underway. And one of those things that were being looked at, as I mentioned, is ART-free remission. So looking at broadly neutralizing antibodies or BNAbs that block HIV strains from infecting human cells and help to facilitate the killing of infected cells. Right now, there's the Botswana proof of concept study. And so this is also all been presented at CROI in 2022. There were 28 children who had received ART from 7 days or less of life and had HIV viral loads that were suppressed at under 40 copies. They entered studies at greater than 96 weeks. The BNAb, the antibodies, were started and ART was held for 8 weeks of overlap. And the ART was restarted if the viral loads went over 400 copies. There was 3 early viral rebounds. 14 rebounded at 4 weeks, and 11 children maintained viral suppression less than 40 copies at 6 months or 24 weeks, right? And so this is just a proof of concept to see if those broadly neutralizing antibodies can be utilized to keep HIV from infecting new cells and, you know, have folks off of the daily regimen. Next. Then there's HIV eradication. One of the most commonly talked about is shock and kill. And basically, so HIV sets up a viral reservoir. And as long as I have one of my memory cells, my CD4 or latent cells infected with HIV, I have all the genetic material to kind of restart a new HIV infection, right? Or kind of reinfect my cells. The concept is that if I could go and find all of those latently infective cells and wake them up over a period of time, stimulate them, that the HIV medications that we have and use today could effectively eradicate the HIV. And so there's these latency reversing agents that are under investigation. Things have worked fairly well in test tubes, but as we know, once you put it into a living being, it doesn't exactly do the same thing. But this is under investigation. And then there's also gene editing therapies with the CCR5. There's people looking at CRISPR genes, et cetera. But if we remove the immune cells and edit the CCR5 gene and transfuse it back, then the removal of the viral genes, you know, we could remove the virus from those latently infected cells. And if I remove that DNA, I remove the blueprint, right, to make more HIV and to kind of do that reinfection within my own body. So there is definitely HIV cure research ongoing. Next. So overall, in conclusion, so HIV incidence overall is decreasing, but there is this uptick in new diagnoses between the ages of 25 to 44. There's ongoing disparities in the populations affected with HIV, as we saw. The burden of HIV diagnosis is in the South and in communities of color, and especially in men who have sex with men, and also transgender women especially. Treatment guidelines recommend starting treatment as early as possible for all people with HIV, including the same day of diagnosis, and integrase-based regimens are the first line for most individuals. There's new areas of treatment development, including long-acting injectables, long-acting regimens in general, and 2-drug regimens. And cure research certainly continues and is focused on both remission and eradication. Any other questions? Let me click here.
Dr. Martinez, I believe there was one question in the Q&A box. Would you recommend hospitalists initiate ART for newly diagnosed hospitalized
Oh man,
patients?
I wish hospitalists would start treatment. I know in the Rio Grande Valley, certainly our hospitals don't have access, but that is not a reason, because your local aid service organizations can help get access even to hospitalized individuals. The pharmaceutical companies, if there's an issue of like, insurance, et cetera, there are voucher programs, there's patient assistance programs that local case managers, et cetera, can help folks get enrolled in and help them get access even through local community pharmacies, so they can start treatment in a hospital. Because again, there's really only 2 OIs that would cause a true need for delay, right? So, I mean, if I was hospitalized with crypto meningitis, well, obviously I need to get that under treatment anyway. But I'm hospitalized because otherwise I'm just really deconditioned, really sick. I've got PJP pneumonia. There's no reason for me not to start treatment. And I wish more hospitalists, more, folks in the hospital would get folks started on regimens faster, because it's just a delay. I mean, folks could come out almost controlled in a 2-week hospital stay because of how well these medications, how quickly they work. That could make a world of difference for an individual and for their community. Remember, individual viral load, community viral load. I wish more folks would start ART in hospital settings. Let me see if there's another one.
Alrighty, well, if there aren't any other questions, I would like to thank Dr. Martinez for her time and expertise on today's topic, as well as for the American Academy of HIV Medicine for this incredible partnership. I would also like to thank you all, our live audience, for participating today. In the coming days, we will go ahead and email all the attendees to receive their CME certification, as well as a recording of today's discussion. Today's discussion will also be added onto the NHMA YouTube page within 1 week. You could also visit nhmamd.org to go ahead and learn more. Lastly, NHMA has partnered with the Centers for Disease Control and Prevention, Let's Stop HIV Together campaign to maximize the effectiveness and reach of the Together campaign by strategically disseminating culturally appropriate HIV resources to the Hispanic community as well as physicians. I'll go ahead and share respective links in the chat for you all to learn more. I just want to say thank you so much, and thank you to our speakers for joining for us today. All right, thank you.
Thank you.